So, as I was just sharing with you, today's webinar will focus on World Cancer Day 2024, which happens to be February 4th. So, on behalf of Kairos Kinetic and Global Biomedical Research Foundation, we welcome you once again for the Thursday virtual webinar series. And today's focus will be on the theme of World Cancer Day, as well as I will focus specifically on cervical cancer and pathways to elimination. So, this particular theme for World Cancer Day for the past 3 years, including this year, is Close the Care Gap, which was initiated in 2020.
Uh, Sorry for the interruption, madam. That we are unable to hear you. I don't know. The problem is there from my side or in general.
Your mic is muted. Please check.
Sorry for that. So, let me open the tray. It's already open, sir said, right?
It's already shared. You just again you screen share. You are only coming out of PPT, not out of the sharing. Yes.
Okay, great.
Full screen.
Sorry.
Yes.
And yeah. Thank you, Dr. Bala, for reminding me because I'm still getting used to this Microsoft Teams. So let me start again. Welcome you all once again for today's Thursday webinar series on behalf of Kairos Kinetic and Global Biomedical Research Foundation. Today's webinar topic is commemorating the upcoming World Cancer Day on February 4th. And my topic today will introduce you specifically about cervical cancer and pathways to elimination. The subsequent next week's speaker is going to address another cancer too. So let me come and talk to you about the theme for World Cancer Day since 2022. It is Close the Care Gap. So 22, 23, 24, all these 3 years, we are observing World Cancer Day with the theme of closing the care gap. And we invite you all to this webinar, sharing certain historical aspects such as I just mentioned, February 4th is globally observed as World Cancer Day. It is an international initiative led by Union for International Cancer Control. Any of you planning to do February 4th events, you can go to UICC website, register your event like what we have done too. So we can register that and upload the pictures or anything related to the event. So this particular concept was started in 2000 to observe the World Cancer Day, and it focuses on making sure this particular third year of this theme focuses on making sure that our leaders know that the cancer community demands a commitment to prioritizing cancer and also creating innovative strategies to confront the inequity, because that is where closing the care gap gets highlighted, and to make investments in the resources to achieve a cancer-free world. With that backdrop, if you look at what does actually the closing the care gap mean really, we always, as public health professionals, we talk about health inequities. But when it comes to cancer, the inequity in cancer care, it actually costs lives, because all of us know early detection is the key for any cancer, especially certain cancers like breast cancer as well as cervical cancer, which are women specific cancers. The earliest we detect certain cancers are pre-lesion states, we can reverse or we can completely make the cancer disappear. But when it comes beyond advanced stages, there is not much we can do. That is why the inequity costs lives, and people seeking care and cancer treatment, they face obstacles at every turn, starting with stigma, discrimination, cultural aspects, poor health seeking behavior for the fear of stigmatizing attitudes from the community and family members, disowning of the family members. Certain things are still highlighted in the context of race, gender, sexual orientation, disabilities and various lifestyles. Certain cancers have a lifestyle factor attributed to it. So all these make a detrimental impact on accessing treatment. And this particular divisions or inequities affect everyone because the numbers reflect on the communities and the nation's health status. So, but the good news is these obstacles are not inflexible and they are modifiable. And I just saw the news like Nirmala Sitharaman announced the digital transformation of India as the biggest element in the budget. So, there are technologies helping us to take this care gap almost to negligent status. So we need to work together and we need to address this theme, particularly closing the care gap. That's how we have to conceive a new way going forward. So if you look at this very quick picture of estimated number of cases from 2020 to 2040, both sexes together, Asia is leading, followed by Europe, North America, Latin Caribbean, Africa, and Oceania. So it's extremely important for us to pay attention to this projected estimates and try to do as much as possible with every individual's efforts to bring these numbers down. So the currently in 2020, that is 19.3 million, which is projected to be around 30.2 million by the year 2040. So let me quickly take you to the rising burden of cancer in India. As you can see from 2020, the numbers are incidents, that is the new cases detected in that particular year. Every year there is an escalation in the numbers, and 2022 it was 14.61, and by 25 it is escalated again. And if you look at the mortality also, in spite of so much of development, treatment modalities being available, access being expanded from tertiary care to secondary and tier 2, tier 3 cities, in spite of that, mortality remains on an elevated mode. And this is where we need to bring all our efforts for early detection and closing the care gaps. And if you can see the common sites, especially for men, the common sites involved in cancer burden in India are lung, mouth, prostate, tongue, and stomach. That is 36% of all cancers are contributed by this. And if you can look at one or two factors or risk factors which contribute to lung, mouth, tongue, and stomach cancers, tobacco, alcohol, these two risk factors play a predominant role. And coming to the female specific cancers, breast cancer, cervix, ovary, uterus, lung, they together constitute more than 53% of all cancers. And if you take the reproductive tract, top four cancers are related to cervix, ovary, uterus, all related to reproductive tract of women, and followed by which is only leading by breast cancer. Right now, breast is the leading cancer for women in India, followed by these three reproductive tract related organ cancer, followed by lung cancer. Again, there is a lot of role of pollution, uh, forever chemicals, and the toxicants we are exposed to in the form of pesticides, water pollution, soil pollution, because these forever chemicals, all of you remember the kind of pesticides that have come into picture from 1950s, 60s, and all these have been forever in the food we are growing still. And that is the reason we are still facing this huge burden of cancers in spite of having certain predictive behaviors at the individual level. So let me come to my topic of interest today, that is pathways to elimination of cervical cancer. This is the cancer which I will focus in depth by discussing about what is the cervical cancer burden, clinical presentation, as well as the public health goals. So to start our conversation today, again, beat the cervical cancer with awareness. Though we are observing February 4th as World Cancer Day, the entire January month is designated as Cervical Cancer Awareness Month. So we are not dedicating one day, but rather 1 month, and we are addressing this cervical cancer because it takes a lot of efforts for women to come forward. Though it is relatively easy, the pap smear, etc., the tools are relatively widely accessible. Again, as I said, the stigma, discrimination, the community and cultural attitudes, these dominate the poor health seeking behavior for this particular cancer. That is the reason I wanted to raise more awareness on this topic. If you look at these numbers, Globally, it remains the fourth most common cancer for women, whereas in India it is second most common, and it is, as all of us know, caused by persistent infection with human papilloma virus. And women living with HIV are 6 times more likely to develop cervical cancer compared with women having no HIV status. So this is one more important burden, because still in our country certain infectious diseases are in the form of emerging scenario in certain risk groups, like transgender women, men having sex with men, intravenous drug users. So in that context, when women are living with HIV, they are 6 times likelier to end up getting cervical cancer too. But the other important point here is an estimated 85% of sexually active women and 91% of sexually active men acquire human papilloma virus at some point during their lifetime. So it's not like there are only certain risk groups here, but 85% of sexually active women are at risk to acquire this infection. That is where the prophylactic vaccination against HPV and screening and treatment of precancer lesions remain the effective ways to prevent cervical cancer and are also cost effective. So when we talk about these three pathways for elimination, one is prophylactic vaccination, which we will talk in detail very soon. And as I already mentioned tangentially, there is the screening concept with pap smear, liquid-based cytology, and treatment of precancerous lesion. This will actually save lives. And cancer can be cured if diagnosed at an early stage and treated promptly. And according to the Sustainable Development Goals 2030, countries around the world are working to accelerate the elimination of cervical cancer by 2030. And if you look at this global picture, age standardized incidence as well as age standardized mortality depicted in the red, the numbers for India are concerning. We are in the second blue shade in the top and second red shade in the bottom figure. So it is concerning globally. We are contributing a fourth of the burden of cervical cancer. So towards this background, the WHO, World Health Organization, has initiated Global Cervical Cancer Elimination Initiative in the year 2020 with the aim of reducing the incidence below a threshold of 4 cases per 1 lakh women years in every country. This is the goal set by WHO to be achieved by 2030. Towards that, they also have a detailed strategy with a vision of a world without cervical cancer. And what are these targets? 90, 70, 90 strategy. To achieve this less than 4 cases per 1 lakh women years, the targets to be achieved through the strategy of 90, 70, 90. 90% of girls to be fully vaccinated with HPV vaccine by 15 years of age. That is the first 90, followed by 70% of the women in the reproductive ages of 30 to 45 should be screened with an effective test. That is the second 70. And the third strategy is another 90% of the women identified with cervical disease or abnormalities should receive prompt treatment and care. If every country could reach this 90, 70, 90% numbers, the target of SDG 2030, that is Sustainable Development Goals target 3.4, is 30% reduction in mortality from cervical cancer. And as I already mentioned, we are moving these strategies towards the achievement of 2030 targets of eliminating cervical cancer. So if you look at the cervical cancer burden in India, it is the second most common cancer among women, as we already listed out. And 83.2% of these invasive cervical cancers are attributed to human papillomavirus strains 16 and 18. These two strains alone contribute to 83% burden of these invasive cervical cancers, and an estimated 1 plus lakh women are diagnosed. But please remember, we were talking about health inequities and other factors contributing to poor health seeking behavior among the risk groups. So this number could only be the tip of the iceberg, and we need to amplify our efforts to early detection methods. On the left half of the slide, you can see that the state of Mizoram is having the highest age specified incidence for cervical cancer with 23.07 per 1 lakh, whereas we are aiming to bring it down to less than 4 per 1 lakh women years, whereas this is 1 lakh population. And we have to really shed more spotlight on these topics, because still 56% of women are succumbing to this disease at an advanced stage, which is totally preventable, totally avoidable if we adopt early screening methods. But the last point of National Household Survey round 5 reveals that only less than 2% of women have ever undergone cervical cancer screening. So this is really alarming numbers, and unless we bring the screening numbers almost 60-70%, as we have seen there in the 90-70-90 strategy, from 2% we need to bring it to 70% in that 35 to 45 years of age among women. That is when these numbers will be reversed and we will move towards elimination. So if you look at the survival rates, this below picture shows the cervical cancer across 11 population based cancer registries in India. And you can see the overall mortality still remains at 51.7, whereas certain places are having high survival rates like Ahmedabad, Urban, Thiruvananthapuram, Kollam, Mumbai, compared to the other places. So we need to really bring this survival rate numbers as close to as 90%. So let me go in depth, because still though we have this information, cervical cancer is still considered the hidden epidemic, because as you can see the numbers, 51% are still dying in advanced stage. That's why it is staying hidden till it progresses to advanced stage, and only 2%, less than 2% women are ever screened for cervical cancer in a pan-India survey conducted by the Government of India. So let us focus on discovering the early signals as well as risk factors. So to be very quickly and precisely to say what is cervical cancer, the right side of the picture shows you the cervix. It escalates from the entry point at the bottom and towards the uterus. So it affects the cervix, the lower part of the uterus. It is a slow growing cancer that can be detected and treated early. That is where our early detection efforts are important. And if you look at the risk factors for cervical cancer, early marriages, sexually active at younger age, having multiple sexual partners without protection, poor genital hygiene, smoking, multiple pregnancies, weakened immune system, and long history of consumption of oral contraceptive pills, along with exposure to these human papilloma virus strains, especially 16 and 18, as I mentioned, 82.3% of invasive cancers are contributed by these two strains of HPV. So these are the multiple risk factors contributing towards the cervical cancer. And I also told you one more thing, HIV infection. When there is a HIV infection, six-fold likelier of cervical cancer occurrence among the infected women. So if we see very quickly the clinical scenario, the left extreme is the normal cervical picture, healthy cervix. Whereas in early stages 1B, we can actually start identifying certain cancerous tissue growths. This is where early screening, starting with a very effective screening tool, pap smear with liquid based cytology, will help us to catch them early and stop from progressing towards late stages of 1B and stage 2B, where there will be a very good frank expression of cancerous growth in the localized areas. And if it is invasive, it spreads to other organs, and also the bleeding and other symptoms will be experienced. Early detection, as I was mentioning, is the key. So all of us should be aware of what are the early symptoms experienced at this particular stage. Early warning signs include abnormal bleeding beyond the monthly regular cycles, pelvic pain, and unusual discharge. With this kind of presentation, women are requested and made aware that they should seek immediate specialist care and explore this further with the available screening tools. These are the various stages which I have just now mentioned, but to be very quick, stage 0 is carcinoma in situ. At this initial stage, the abnormal cells are developing, but they are confined to the inner lining of the cervix, but not invaded the deep layers of the cervix. At this point, The treatment options include surgery and localized procedures, which offer a very high chance of cure. That is why we say like early detection saves lives. And stage 1, it is limited to cervix, but it involves surgery, radiation, and a combination therapies to remove and destroy the localized tumor. Whereas in stage 2, the cancer extends beyond the cervix, but not beyond the pelvic side walls. And still, the treatment strategies include surgery, radiation, and combination therapy so that we will stop the further spread of the malignancy. Whereas in stage 3, the cancer involves the lower vagina as well as pelvic side walls, and this is where the invasiveness starts to spread beyond this localized area or pelvic wall, and a combination therapy is completely required to combat the disease. Whereas stage 4, this is an advanced stage, that is where a lot of women are dying in the advanced stage diagnosis, spreading to other organs like bladder and rectum. And it also includes a complicated profile or cocktail of therapies, including surgery, radiation, and systemic therapies with some anti-cancerous medications. So, with that background, our entire focus is on early detection, and Pap smear is a simple screening test which plays a pivotal role in cervical cancer prevention, as it identifies the precancerous changes so that the healthcare professionals can intervene in the early stage. And the right side of the picture helps to understand what can be expected by a woman when she's appearing for a pap smear examination. We need to be mentally prepared because the first step includes the speculum insertion through vaginal wall. This is the only uncomfortable, minor inconvenience and uncomfortable part of this examination, but it is very important for thorough visualization as well as exposure of the cervix, so that in the second step, a bristle like brush with a swab is inserted into the vagina, and it collects the cells from both sides of the cervical walls and inserted into a capped tube and sent to the pathology lab, where a smear examination will be performed under LBC, that is liquid based cytology techniques. So, as I already mentioned in my October presentation, in Rela Hospital in the month of October, I underwent both screenings for breast cancer as well as PAP. This is how a report will be generated using liquid based cytology, and we will be given a PAP smear interpretative result, as in my case negative. But that is how we need to move towards. It's not just raising awareness, having knowledge should lead to action. And this is my second mammo as well as second pap smear, because I initiated it at the age of 40 and I has completed 45 last year. I was asked to repeat after 5 years, which I repeated. So I recommend all the participants having this kind of profile who fit into this age gap. Also, if there is any family history of cancers, it is highly recommended. As a professional myself, as well as a screening individual myself, please undertake this screening test at the earliest, looking into your health profile as well as other profile, which necessitates us to undergo these periodic health checkups. So now let me focus on the prevention aspect, which there is so much of attention these days, because the first 90, 70, 90 is talking about 90% complete vaccinations for adolescent girls by the age of 15. That is that recommended guideline by the WHO. And right now, 100 countries are already implementing it through the national programs for their adolescent girls. India is yet to administer that kind of nationwide universal immunization program kind of protocol for human papilloma virus vaccination, and we sincerely hope it will happen in this year. HPV infection is preventable with the right kinds of measure, including HPV vaccination. And as I'm going to share with you, this particular virus is the leading cause of cervical cancer, especially 16 and 18. And these vaccines, most of the vaccines available in the market are quadrivalent, which covers 6, 11, 16, 18, 4 strains, and it offers protection. So we need to encourage more and more eligible adolescent girls less than 15 years to be completing their 2 or 3 doses of the schedule of cervical cancer vaccination. Ideally, it is recommended for both male and female children. Right now, the focus of India is on female children, but ideally, both male and female children should be receiving this vaccine. Males by the age of 9 to 11 years, and females before the age of 15 years or before administered this vaccine to be administered before sexual activity begins. But a lot of evidence is shown that even after commencement of active sexual life around 30-35 years also, in the adult stage, if women are receiving at least one dose of HPV vaccination, it is still offering protection against this particular cancer. Evidence is mounting towards that. So there is a lot of evidence for us to keep that in mind and opt for voluntary HPV vaccine, because it is not included for adults in the national program. And even for adolescents less than 15 years, the government of India is right now considering with a lot of other pilot studies undertaken in other parts of India, which I'm going to share with you now. So if you look at the India's progress in HPV vaccination, this vaccine is approved by technical group and launched in Punjab as a statewide school-based program in the November of 2016, followed by Delhi government, which also sponsored this opportunistic vaccination. That means you are offering and clients can opt for it and choose for it for the school-aged girls of 11 years in the year 2016. Recently, Sikkim also launched a statewide program in 2018. There is a lot of published evidence that Sikkim model of delivering HPV vaccination could be replicated across India. And if you look at the evidence for the vaccine efficacy against the persistent HPV 16-18 strains of infection at 10 years of age after 1, 2, or 3 doses of quadrivalent HPV vaccine in girls of India, which is a multi-center prospective cohort study, the study found that among the younger ages of 10 to 14 years, the recipients of even a single dose elicited 97.7% to 98.2% of detectable binding antibody titers, right? At 10 years post vaccination. This is more important. It is not that you gave them today and you tested them tomorrow or 1 year. Even at post 10 years of vaccination, 97.7% and 98.2% detectable binding antibody titers with single dose has been reported by this study from Partha Basu, who is right now with the WHO, as well as the proportions among those receiving single dose at the age of 15 and 18 years, beyond that cutoff of 15 years, was also found to be 92.3% and 94.2%. This is a very, very strong evidence. And a lot of these studies are helping the policy shaping at the national level. And another study, the same study was quoted widely in the newspapers. And we hope that very soon India will be able to roll out this program pan-India. And if you look at the vaccination and screening barriers, both for pap smear as well as vaccination barriers, this particular study by Tulasidaran et al. In 2019 listed the cost of the vaccine as one of the major barrier for vaccination, safety of the vaccine, lack of awareness among healthcare providers, beneficiaries, families, and communities to encourage adults and girls to be receiving these, and not perceiving that they are at risk, as well as certain concerns about the side effects of the vaccines, as well as the cultural issues associated with recommending this vaccine for young adolescents less than 15 years. When it comes to cervical cancer screening barriers, still lack of awareness is prevailing among our rural and semi-urban and low-income group women. That is where healthcare professionals' role becomes much more amplified. When we serve in tertiary care hospitals, especially in rural pockets, we need to take every opportunity to raise this awareness and allocate adequate resources as money and resources as time, so that we educate our communities and provide a related barriers, especially the discomfort with pelvic examination by male care providers. We need to encourage all genders of healthcare professionals to be able to perform this, because in certain parts of India, especially I have traveled widely for my job, and I have seen especially Maharashtra, Central North India, still OBGYN providers are 60% male providers. So we need to encourage male providers to offer these screening tools in spite of this gender related preferences, and not perceiving the need. As we talk to some of our rural women, they just believe that they are in a monogamous relationship, they are not at risk of acquiring these kind of infection, but poor genital hygiene, increasing age, lowered immunity, long-term use of oral contraceptive pills, all of them can weaken the immune system and put any monogamous relation woman at risk, because other factors will not be considered if we focus only on monogamy. Now, with this background, I would like to introduce the Serum Institute of India's quadrivalent Cervavac vaccine, which is developed in partnership with Department of Biotechnology, Government of India, and DCGI, that is the Drugs Controller General of India, has permitted to offer this vaccine for both males and females in the age groups of 9 to 26 years, which we already discussed. And it was launched in the year 2022 September. So more than 1 year of evidence is gathering. Post-market surveillance data is pulled up. And for future rollout, there is a consensus among the implemented partners as well as beneficiaries as well as the policy advocates. The price is one of the major barrier, because the private vaccines, Gardasil, etc., which were available in the market before the entry of Cervavac, were costing anywhere between 3,000 to 10,000 per dose. And certainly we need 2 or 3 doses in adolescent age group less than 15 years. So it is really cost prohibitive. But with the Serum Institute of India releasing Cervavac vaccine, the pricing can be within the range of 200 and 400 rupees per dose, and this will widely escalate the coverage of this vaccine across the country. And as I said, these are the latest news covered 2 days back in the newspapers. Center is yet to take a call on beginning the HPV vaccination campaign for girls. This is reported in Hindu newspaper. So the pilot studies from Punjab, Delhi, Sikkim, etc. are really a very good evidence for us to take this to the pan-India level. And government is right now in the policy discussions right now to roll out. And we hope with the adequate level of policy advocacy, we will be able to shape the policy to roll out in India this year. And the recent survey on the January month's cervical cancer awareness month related news coverage, there is this news which says that 88% of Indian working women lack cervical cancer vaccination. This is done by a health insurance company. So they are advocating that of these unvaccinated women, again, 63% are oblivious to the existence of both vaccines and screening. So there is so much of work for us at the level of awareness itself. There are a lot of numbers to be covered. And another news coverage says that don't delay the campaign against cervical cancer, because we are accounting for 1/4 or 1/5 of the global burden, and estimated that 453 million Indian women above the age of 15 are at risk of developing cancer, because I already listed out various risk factors for the benefit of the audience. And WHO has recommended all adolescent girls be given 1 or 2 doses. And Dr. Partha Basu et al. Study reveals that even after 10 years of receiving single dose, the antibody response is really, really impressive. So we need to move towards that recommendation, at least 1 or 2 doses for all adolescent girls as per WHO. And over 100 countries have implemented this right now. So let me summarize so that we can refocus on what are the major points. In spite of cervical cancer being the second most common cancer for women, it does not remain a woman's problem. It is everyone's problem, because cervical cancer usually affects women at the peak of the productive life, less than 45 years. And thus, in addition to the loss for the families losing mothers, sisters, daughters, etc., it impacts the national incomes, because we are seeing more and more women workforce coming into the formal and informal sector. So this actually takes a heavy toll on that particular economic angle also. Apart from that, no one should die. The numbers speak for themselves. 51.7% is the loss of life when women are detected in the advanced stage. So no woman should die from cervical cancer since it is preventable. First tool is vaccination, even adolescent and adult vaccination, followed by age appropriate periodic screening with pap smear and liquid based cytology techniques, so that early catching can lead to interventions, both surgical, radio, chemo, and that will help further prevention of spread of this cancer to other vital organs. These two things, no one should be dying and everyone's problem, to create awareness as well as bring people for early screening, it should be a commitment by all. On this World Cancer Day Eve, we request all of us to take a stand within our families, neighborhoods, communities, whether we can spread the word that there are certain tools available like this, also to encourage eligible brackets of adolescent as well as adult women to avail these services both at the private sector as well as very soon in the government sector. So women should be informed and taken control of their health, undergoing screening tests when appropriate. They can also inform their friends and relatives and support them in their decision to, facilitate or enable them contacts. We are all working in medical school, so we can bring some referrals. If someone wants us, we can put a word to other medical schools so that our neighbors and friends get good services. Men can also help. That is the reason we wanted all men to be part of these seminars, because they can encourage and support women in their families to prevent cervical cancer through vaccination and screening, because all of us know women sacrifice so much at the level of the family and put their own welfare, their own wellness and health in the back burner. But this kind of awareness should bring them to the forefront so that they can avail these preventive and promotive services. Parents, guardians can facilitate vaccination. The topmost barrier for acceptance of vaccine after the cost factor is cultural attitudes. So parents of adolescents of eligible age groups of less than 15 years, we should educate them so that they will encourage the children to be vaccinated and also learn about the benefits of the vaccine. It's not that we are taking care of these infections, because the benefits extend post into the adult life. And professionals and teachers, these are the most critical key influencers, because school teachers, professionals in the schools, headmistress, principals, and other counselors, they play a very key role in encouraging mothers, educating them, addressing their concerns or any fears related to the uptake of the vaccine, and bring them towards accepting these vaccines when they are offered in the government program or at the private level right now. To summarize once again, this 90-70-90 strategy is very, very important and critical for us to achieve the 90% full vaccination of HPV by the age of 15 for all eligible girls, 70% of the women to be screened by the age of 35 and again by the age of 45 with an effective technology like pap smear and liquid based cytology. Whoever are detected among them, 90% of them should receive the treatment which is appropriate for the diagnosis. And we need to get these numbers in place so that we can achieve the elimination by reaching less than 4 cases per 1 lakh women years by the year of 2030. So we can all talk about elimination and move towards we can end the cervical cancer. The first and foremost thing is getting informed ourselves, passing the information through appropriate mediums, through appropriate forums, to appropriate pockets of the country, because rural and semi-urban women remain still the target of these kind of lack of information and getting screened and getting vaccinated. With that, I would also like to focus this latest campaign from Serum Institute of India. All of you can see Janvi Kapoor is the ambassador. Everywhere she's talking widely about let's unite for a HPV free world, pledge to prevent. So there is a beautiful video taken by Serum Institute of India to promote awareness. So we can all share this among our groups, as well as any family members requiring further information. We are always available here. So with that, I conclude my presentation and stop sharing. So if you have any further questions, I'm right here moderating my own discussion. So I welcome all of your questions. And once again, thank you for your patient listening. I'm seeing some 40 people logged in. So thank you all of you for your patient hearing. Dr.
Madam,
Vijayta says, yes, sir. Dr. Vijayta says, Dr. Sree, wonderful talk. If possible, please share the PPT. Definitely, we will be sharing the PPT as a PDF document immediately in the webinar group. I think Dr. Kannan sir is doing a webinar group. I will share it through that. Otherwise, if you want me to send you a personal email, I'll try to do that. Thank you so much. Maharaja Pandian says, very informative, helpful. Thank you, Dr. Maharaja. Please share the PPT as well as the message from today in your respective groups. Thank you so much. Sir, Bala sir, over to you.
Yes, madam. Yeah. So it's excellent talk. Thank you so much. Very good information and including Indian data. And so I have a few questions. The first one is you mentioned that people those are living with HIV, they are likely to have 6 times more riskier in acquiring HPV infection and causing cervical cancer. So this is even in the presence of medication, in the presence of ART, or because know that earlier
No,
that we had cut off, and then only that we started treating for HIV.
yes.
But in the current period, recently introduced a test and treat policy where that we initiate ART as soon as that we see the positive cases. So, uh, is there
Very,
any?
very pertinent question. That's why I only highlighted HIV without heart. So that six-fold risk is only with HIV infection in the absence of heart.
Is there any data that after initiating ART that still they are likely to have some minimum level of risk in par with
Yes.
immunocompetent people, or
Y- Yes, sir. Even with HART, if there are other opportunistic infections where the heart is not responding or resistant or second level or second level of ART and all, such women are still presenting with cervical cancer lesions, but not like very aggressive presentations like in the absence of heart. The literature still mentions that HIV without heart remains six-fold amplifier of this cervical cancer, and HIV infected women on heart with good viral suppression have adequate protection like non-HIV women. Okay, only with HIV plus heart with poor response to the heart regimen, that is the group where there is a concept of cervical cancer being one of the prominent expressions of cancer among this group of women. But in the context of your question, one more angle here is there are, that is why I highlighted to the HIV epidemic right now being driven by certain vulnerable populations emerging as pockets, among them intravenous drug users especially. A lot of studies in this high burden states of this HIV highlighted that women are not being tested for HIV and not implemented on ART immediately, like generally our acceptance is as is countrywide policy. Certain states are lacking in that. In such behaviors, take for example, I will take one example of IVDUs. IVDUs have female partners. The IVDU female partner who is also IVDU is not being periodically screened for HIV. Such women are remaining out of ART focus. And for IVDU practice of getting intravenous drugs, certain of them are indulging in high risk sexual practices. Again, STD, again, poor transmission of this HPV, multiple strains. So, there in such pockets, it remains a concern for us to highlight HIV angle. But otherwise, in general, as you said, with the current test and treat policy, invariably all women tested and recommended for the immediate ART initiation. The picture is not really that broad, but it is in concentric spots.
okay, thank you. And other question is that why we have age capping by vaccination should be done by 15 years old. Why not beyond that?
Can I get your question once again, sir?
Yeah, so that the vaccination should be done by the age of 15,
Yes, sir.
and
For the
yeah, so why
recommend.
not? Yeah, why not beyond 15?
No, sir. Beyond is also available because
Okay.
if you see the
What's
primordial
the rationale
prevention.
behind that?
Yes, sir. The primordial prevention concept is preventing the emergence of the risk factor. HPV infection is a risk factor, right? So it is through early initiation of sexual activity in the adolescence. The general perception when we do the age of sexual activity initiation in India, it was found 9 years to 11 years. among men, boys and girls. So if we take it as a cutoff of 9 to 11 years as a range by which sexual activity is being initiated on average, and if you introduce this vaccine in adult life rather than before 15 years, the risk exposure of contracting any strain of HPV is already established. So in the name of primordial prevention, you want to prevent the emergence of the risk factor itself. WHO says the evidence is strongly recommended if you provide this vaccine before the age of 15 years. And there are lots of studies from London, especially UK, where after initiating this vaccine as early as 9 to 11 years for boys and before 15 years for girls, in Great Britain and all, so much of evidence of reduced numbers, incidence as well as mortality has been documented. So in the primordial prevention angle, we are recommending a universal immunization program to facilitate the rollout of this HPV vaccination for all our adolescent girls in the beginning and eventually for boys also. But coming to your second question, adult vaccination, there is also evidence that when women receive the first dose of this HPV vaccine, even at the age of 35, after initiation of sexual activity, etc., etc., there is still offering protection around 82 to 91%, depending on various country studies. There is mounting evidence, which I already mentioned, adult vaccination. Even if someone misses that 15-year age gap and they are in the 35 years, the current evidence is pointing towards initiating at least one dose of adult vaccination by the age of 35. But that is right now available only in the private sector.
Thank you.
So these are the two very, very important critical points. And whenever last year also we were attending this World Cancer Day focus on cervical cancer, a lot of our professionals from Adyar Cancer Center and in the city who are actually delivering this tertiary care, private sector vaccinations to the adults, as well as a variety of testings, are advocating that adults are also coming forward, especially in the high income group and educated backgrounds. They are adopting for this adult vaccination above 35 years also in our country, especially in our Chennai. Right. Thank you so much, sir, for that very in-depth question, because these two questions are really to be emphasized once again because of this confusion. But otherwise, there is a clarity. Adult vaccines can be availed in the private sector, and pilot programs have been delivered for adolescent girls, and we hope that universally it will be rolled out very soon. And Dr. Partha says, good evening, ma'am. Please explain once again about HPV vaccine dosage. A variety of vaccines are available, Dr. Partha, and quadrivalent vaccine 6, 11, 16, 18. The ideal dosage, ideal schedule is 3 doses given in the private sector as of now. And pilot programs that particular states only have implemented as a pilot program to study the feasibility, efficacy, the systems of delivery, and etc. etc. But it is minimum 3 doses a schedule, ideally, which offers 95 plus protection when taken less than 15 years of age. And we will also be able to encourage more women to go for this adult vaccine. And when we go for an adult vaccine, it typically a provider will offer you HPV pap smear screening in certain with certain risk profile. They are also offering this testing for HPV strains. So we can also do all that kind of extensive workout if the patient's profile or a client's history, if there is a family history of cervical cancer, if there is a recent history of cervical cancer among siblings, elderly siblings, or first degree, second degree relatives. It will not be routine vaccination plus pap smear. Some other extensive investigations will also be recommended to rule out the early expression because of the family confluence.